I have a question for the audience. If you have a patient, single vessel LAD, do the cath, and you've got a fuzzy lucency of a vessel and brisk TIMI-3 flow, I'm just curious how many people would use advanced imaging for that, and how many people would just stent it? So those that would just stent it, just raise your...
STEMI or non-STEMI?
No, non-STEMI.
Non-STEMI?
Non-STEMI, ACS, non-STEMI, absolute LAD, and it's got a fuzzy lesion, okay, which is not uncommon. I'm just curious how many people just stent it. So if you would just stent it, raise your hands. Okay, and if you would image, raise your hands. All right, great. And so then what is the data there to say that you need to add imaging to do that? Because, the original practice was just, if you find it, fix it.
Right. So there is some data to suggest if you look at the underlying plaque, if it is perhaps a plaque erosion, and you have TIMI-3 flow, a patient is stable, you may be able to get away with just medical therapy without sending those patients. A plaque rupture is a totally different animal. There's no data for medical treating those patients. If you identify a plaque erosion, you may be able to get away with medical therapy. And there's some data to support that from Japan and
then you didn't really speak at all about doing fractional flow or any physiologic measurements. How does that fit in? This is all kind of imaging based and not really physiologic. So does physiologic imaging or assessment have any role in ACS?
So if you're talking about the culprit lesion, it's a different issue versus you're talking about a non-culprit lesion. If non-culprit lesion, you can definitely use physiology to assess the functional significance of that stenosis. When you're talking about a culprit lesion, it's a little bit different because the physiology of that vessel, because of the microvasculature, may be completely altered. So I'm not sure if there's any role to assess a functional significance of stenosis of a culprit lesion that had a plaque rupture with distal embolization, given the altered microvascular physiology.
Yeah, I think that I really agree with that. I mean, I think when we looked at all the FFR stuff that was done originally, FAME, it was all in stable coronary disease. And then my problem is that some of these arteries are with a huge plaque rupture with a thrombus burden, et cetera, may not be physiologically significant, but still could be prone to thrombosis in the follow-up if it's not fixed. And if you go back 20 years to all the ACS trials, the biggest difference was not mortality, it was reinfarction and repeat intervention. That's kind of what drove all the positive trials in ACS. And so what I don't know with these incredible antiplatelet, antithrombin strategies that we have right now, whether you couldn't passivate. So I think there still is going to be an interesting going forward on pharmacologic pacification of some of those ruptured non-stenotic vessels. There was a question right there. Right. Yeah.
Yeah, I mean, if it's a plaque erosion, you got a TIMI-3 flow, patient stable, not having chest pain, then I think those patients, you could potentially get away with medical therapy, with DAP therapy. And again, there is some data to support that. Whether or not you bring it back for imaging, I'm not sure, but there is definitely data for plaque erosion, stable patient, TIMI-3 flow, non-significant stenosis to medically treat those patients.
So a couple quick comments. First of all, we talked about this as STEMI and non-STEMI, but I think they're very different, and your approach is very different. So if you asked your question about that hazy area in a patient who had STEMI, I fix it.
Right.
And I think they're different. And because you knew that patient already had ST elevation, I think it's important to fix the culprit. So. But to follow, if in a large STEMI series with 6,000 people, it turns out about 2 to 3% of people have multiple culprits. So that definitely happens that you have it. A second one is about 10 to 15% of people had no culprit. And one of the best things, I agree with imaging, think FFR can help you in the lab, but really the most helpful for that true no culprit is doing a cardiac MRI. And it changed our diagnosis in about 30 to 40%. So I think it can be really good. Another point that you made I think is really good, and I'll illustrate this from a case from last week. I think the LV gram at the time is really important if you don't know. When you approach STEMI, you should see what the EKG shows. You should have an idea in your mind what the culprit is. And if something's not clear cut, you get more information. And this is a patient who came in with EF of 15%, pulmonary edema, had anterior ST elevation, but not very big bump in enzymes, had a very calcified but stable looking 85% mid-LAD. That literally, if you're going to fix it, you're going to have to use a rotoblade or a CSI. But it wasn't just clear, so I actually did an LV-gram and she had Takasubos. And you asked her what happened. Well, she had just gotten in an altercation with her and her husband in a car thing. So what we did is did nothing, let her recover. EF was 45% the next day, and she's coming in next week to be part of the Shockwave trial. So the right answer for that lady was to do nothing, because it was not a culprit. It was a lesion in the setting of Takasubos.
So one thing is great talk. I know Henry Ford, you have a very established shock program. What's your recommendation for places that they want to start this? I mean, the collaboration with the surgeon, and how do you actually develop a good shock team to work? Because I think enthusiasm early on might be just too much. You want to do everybody, and then you get bad results. So how do you manage that?
If you go alone, you go fast. If you go together, you go longer. So it's very, very important to bring in all the shock program. It starts from the ER all the way to the social worker who's going to help you with the patient, the palliative care people. You have to talk to them. It's very, very important to assemble that team and be cooperative with that. Otherwise, you're not going to be able, and you always need the surgeons. You cannot actually completely not ignore them in this. You can do it, you can be helpful, but as a team, you achieve much better results. So I think you start by assembling the team, and then we have actually a resource. This is one of the resources if you want to start a shock program. Bill is kind of heading, him and Bob are heading the National Cardiogenic Shock Initiatives. You can actually call us and we'll be able to help you with that. And we can share experiences, and the Sky puts a conference in September in Boston about shock. So all this knowledge, now finally you're paying attention to shock. Bill O'Neill been talking about shock for the last 30 years. Now we're catching up to him.
So I have a question, Carl. So there might be an interest also for the hospital because there's reimbursement associated with having ECMO program, right?
So thanks to Sky, actually, the lobbying, we went back to reimbursement. They changed that decision about, it was decided that if you place the ECMO in a surgery, it's reimbursed full. They decreased the reimbursement for the cath lab, thinking that the cath lab patients are less sick. In fact, they are actually more sick. And so they finally, by Sky efforts, and I think the ACC helped out.
Yeah, what I'm trying to say is that it would be, if you want to start an ECMO program, it would be an easy sell to the hospital administration.
Absolutely, absolutely. It's actually very profitable.
So I wanted to make a couple of comments, especially for fellows, to understand the difference between VV ECMO and VA ECMO. You need a good functioning heart for the VV ECMO, whereas the VA ECMO is for both respiratory as well as a hemodynamic collapse. So be aware of that. The second point I want to make is always be wary of an exit strategy when you're putting in your ECMO. Know how you're going to wean them off and what's your plan going to be to wean it off. And the third point I want to stress, as Dr. Alswad mentioned, is the anticoagulation. Be very, very, very cautious about that. I recently had a case where I did a STEMI on a patient who was coding, and he was having chest compressions. We put in an Impella, put in an ECMO, but the chest compressions were stopped short of putting in those two, and then he had an LV thrombus. So you have to really, really be careful about cases like those. Continue the compressions or make sure that the heparin's therapeutic.
One thing is cardiogenic shock, as we all know, is really a clinical diagnosis. I mean, we can't really use just one single parameter to make a diagnosis. So it is really a multi-organ kind of dysfunction because of hyperperfusion due to a cardiac reason. So all these numbers that we use in cath lab, systolic blood pressure less than 90, or mean arterial pressure less than 30 of the baseline of the patient, or even the cardiac index by right heart cath, these are all what we have used in trial. So really, for each patient, we should actually consider, these parameters and not only one actually number to go by and decide about hemodynamic support. The second point I want to make quickly is about the point that you mentioned about vasodilation. So about 20% of patients with cardiogenic shock eventually actually will have vasodilation because of high level of inflammatory cytokines, interleukin-1, interleukin-6. And these patients, I heard from residents, they love to order like procalcitonin to see if they have infection or not. But apparently in heart failure patient, procalcitonin could be high too. So really, as you said, this is, again, I don't think most of these patients, they have infection at the same time. So we have to be cautious on labeling patients as mixed actually shock, and many of them actually may turn around. So that.
Absolutely. So the cardiogenic shock is a syndrome. It's a complex syndrome. You can't really depend on one number. We've seen patients with the blood pressures 170 and cardiac index is 0.9. So this patient, despite normal blood pressure, still cardiogenic shock and just hanging on with their dear life to the last catecholamine, clamping their vessels, and they're gonna reach a point the blood pressure gonna be 60. So you have to look at the totality of the picture of the patient. One of the things I learned that if the heart rate in a patient with a STEMI, if the heart rate above the number of the heart rate is above the systolic blood pressure, that patient is actually going into shock. It's very, very important to be much vigilant in those patients. And another thing, this is a plea, please go back to the right heart catheterization. We discovered in the Cardiogenic Shock Initiative, those patients, actually I did not put that slide, but those patients who received right heart cath have actually better outcome than patient who did not receive right heart catheterization. You can't do the Stevie Wonder therapy, like doing it blindly. You have to know the data.
So just to play devil's advocate, so the right heart cath has been kind of out there because there's data that was saying, well, the right heart cath patients actually die more. That's probably selection bias.
Exactly.
I think we're now understanding shock a little bit better, but also takes a mindset because many interventionalists will go take care of the patient, reach their futility line, their own futility line, not the patient's futility line, and then stop doing stuff and then lose all that time when the morning comes, when now the patient is just more profoundly in shock. So I think it takes a whole hospital, takes a whole mindset, and implement those and hold everybody to the same standards and protocols that you institute. Otherwise, you're not going to be able to have a successful program if you have disparity among operators.
Yeah, what we found in patients with cardiogenic shock is actually a process. So you can put in an Impella, and you can't just send them to the ICU right away. So what we start doing now, we stay in the cath lab. We stay about 30 minutes or 20 minutes, and we shoot the numbers again. And you have to demonstrate improvement. You're titrating, if the patient on so many pressors, you start titrating them down because the Impella is a great, but we have a bigger options. As I saw, the bigger cat is much stronger than smaller cat. So you have to kind of sit there in the cath lab, go take a coffee, whatever, if you don't drink coffee, take your gloves, go talk to the family, tell them how grave the situation is, and then go back and do some assessment, and you'll find out. If you send them directly to the ICU and they start spiraling down, it becomes a lot harder to bring them down.
So I have 2 comments or questions. So the CPO is for a patient who is already on pressors, the CPO is not, you can't use the CPO. Like the other panel members mentioned, the patient is in shock. They probably will not have the right CPO. And the second comment I want to make is for patients with a borderline PAPI score, like if they're 0.9 or somewhere sitting around there, probably do you try milrinone or before jumping to an RP Impella or RV support?
I'm biased against milrinone and dobutamine, and because they are actually do not improve survival. However, sometimes if you want to weigh the risk and the benefit, so if you want to add a right ventricular support or upgrade from a CP to ECMO, sometimes if you reverse the reason why the RV is going down and still the RV is going down, I actually look for more revascularization of the RV marginal if I could before I upgrade. But if that continues, If they're complete revascularization, then I'll add some milrinone and trying to see, or dobutamine. The milrinone will lower the blood pressure. The RV respond to that, but I kind of more tend to use mechanical support when I have a borderline situation like this.
Dean, that was a fantastic lecture. I think one of the real problems that we have is sort of outcome reporting data, and Michigan has a pretty elaborate process for PCI mortality. So, in that patient that you did the myocarditis, if there had been a culprit, and we would have put a wire, and then he would have had brain death, then it would have been a PCI mortality. And so, I'm just wondering, how do you face that? I mean, nationally, is there any movement afoot to sort of try to exclude these patients or segregate those so that they wouldn't count in the overall PCI mortality rates?
Yeah, it's an excellent point, and we do have that issue. If you look when we initiated our program and look at our CAP PCI registry data, we have bumps in mortality. We've had bumps in what you would expect, bleeding, because essentially all these patients who are put on ECMO will get transfused, and most of them all get acute kidney injury. So it's a real problem that we face, and we need to address it. But as a whole, as an institution, we feel like this program can serve our community. We have about a 30% survival with good neurological outcomes, and if you look at the national data, it's about 20 to 40%. So we're right there. And so as a whole, we decided as an organization that we're going to move forward with this despite the public reporting.
So really outstanding presentation, and I think for everybody, how many in here have an eCPR program, are involved in it? So scattered but growing. So context here is every one of these people would have died, or 95%. So these are dead people. And if you do this correctly, you can actually I think you can get to close to 50% survival. But it's not for the faint of heart, because this is now people who are in your cath lab who die. So how do you deal with that from a morale standpoint, from a process standpoint? Because even if you're doing the best program, 30% of them will probably die in the cath lab, right? You'll stop in the cath lab.
Yeah, that's an excellent point. It's actually extremely difficult. Being in the state of Ohio, we have these patients that come through. A lot of them are young, and unfortunate. We've had a handful from drug overdose too. So then you're going to their parents, 30-year-olds and 20-year-olds and 40-year-olds, and it's extremely difficult. I think I think you have to focus on the success of your cases. We tend to, for instance, I showed you we have venues to go over these cases. One's M&M, but M&M, they're all going to have complications, but we also, during M&M, show all the success cases. Our staff, we now have come to our M&M so they can see the goods and the bads, and I think that's important. I think you have to focus on the positives and also go over the negatives so you can learn from them to move forward. But that's a really good point, and it is difficult. There's no doubt about it. Yeah.
I have a quick question. So I didn't see an age listed on your criteria, so I just want to know how you deal with the older patients.
What's interesting, we first, the age cutoff when we first started was 18 to 65, and our first patient, he was 68, he would have been excluded. We didn't know his age, so he went on ECMO and he survived. And that was based on just talking to other centers who were doing it. We were trying to start at least somewhat conservative, and then as we started to grow our experience, the exclusion criteria that EMS has is 18 to 75 now. But I'll be honest with you, it's very difficult in the field. Unless you have a wallet on you or a family member, they're not going to know. And so that's our age cutoff. And that's, again, we started off with age of 18 to 65, lactates of 12. And then as we started to grow the program, have more experience, we started to expand to 75, lactates to 15. And that's where we stand right now.
So a question. So those patients who are lucky to show up at your hospital, so do you guys have a diversion system where if someone needs eCPR, get sent to your hospital exclusively, or how do you do?
Yeah, so the way the program works, now this is only Columbus Fire Department. There are several EMS that are townships within Columbus suburbs, and so this is just city proper. So if they are in refractory VT, it is exclusive to our institution. If they achieve ROSC on the en route to our hospital, and there's a closer hospital nearby, they will divert to go to the closer hospital. I will tell you, we have tried to do a citywide program. so we can capture more patients with the other institutions. But I will tell you, they're very hesitant, the administrations from the other hospitals, to jump into this, and for reasons that were brought up by Dr. O'Neill, it's very difficult. And so that's the way it's been worked exclusive with Columbus Fire. But if they do achieve ROSC, they will divert to the closest hospital.
Okay.
Dean, you were talking about target temperature management. You're not routinely instituting hypothermia. I thought there was pretty decent data on neurologic recovery with that, and you can do that with ECMO. You don't have to have another device, right? You can just use some sort of cooler as you have the blood flow go through it.
Correct.
Talk about that a bit.
Yeah, we were doing like 33, and then having discussions with our neurocritical care team and with our intensivist. From some of the data that's been released, they think that 35, 36 is sufficient. The key, my understanding is to avoid fevers, and that's the key. So we've moved from 33 to 35, 36, and we do regulate it through the ECMO, that's correct. And we initiate that in the cath lab.
So that was excellent, and we need to move on. But one final comment is, first, it takes a lot of work to this. You really have to have a team-based approach. But it is incredibly gratifying, because if you look at the long-term outcomes of these people at 6 months and 1 year, the majority of them have almost near complete recovery. So this 50% of people that you can save, it is incredibly gratifying. I think every major city should have a program like this.
Thank you for your leadership in this area. This is absolutely spectacular. I'd really reemphasize what you said about looking at the literature. I'm just reviewing a paper from a huge Korean experience, and they say acute MI, shock, STEMI, blood pressure less than 90 for 30 minutes, and they've got a 30% mortality. And that just doesn't resonate, because you look at all the other trials, there's a 50% mortality. So there's something about the way that they're defining it, we're defining it. We're not really comparing apples to apples. So I think that's really kind of, if we're even going to talk about registries, they have to kind of be talking about the same patient population.
It's so true, and that's what really stimulated this, because you consistently look at it. And again, our registries are really the current way they've been, the past ones, NCDR. As much as we've learned from NCDR, cardiogenic shock and cardiac arrest, we don't. Yeah. Because there's no, you can't distinguish between the patient with a wedge at 25 and the patient who's on a Lucas device who's been shocked 80 times. And they're not the same patient.
Yeah. So I have a question, Tim. So very nice lecture. Can you go back and do like a patient-level meta-analysis and reclassify all the patients enrolled in SHOCK 2 and other shock trials like IMPRESS, and then kind of retune and rearrange the data so you can look at all these degrees of shock?
Yes.
And then analyze the impact of therapy?
So
it would be retrospective, but very, very interesting.
Yeah,
so
that's a great point, and the nice thing that this has already stimulated is really Jake Jensen at Mayo Clinic has 10,000 consecutive people in the CICU, and he did exactly that by using criteria that they used their database, was able to put people, we think, pretty reliably into the A, B, C, D, E, and then looked at the more, and it's absolutely predictive. Not surprising. And actually, when we had these comments on the symposium last year, I went through and said, okay, this is what I think the mortality for A, B, C, D, and E were. And they're actually, we were within 5 percentage point of everybody. Because you know the patient who's in E, that patient's mortality is going to be around 70%, right? 60, 70%. They're ongoing arrests, you don't know, whereas in the A patient, that mortality should be, under 2%.
That's true.
So we want to, it's in the interest of the format, it's 10 o'clock.
One quick question.
Please. Yeah.
Tim, Nick Burke, phenomenal work, building on your extraordinary history with STEMI and acute coronary syndromes and whatnot. It's really to be applauded for all the people on the podium. Why was heart rate excluded in the SKY stuff? I didn't see that on any of the...
So it's a really great point, Nick. So heart rate is, right now I really wanted to point out the classifications are not so dependent on any one thing. We have general rules about there, and certainly I think an elevated heart rate can be high in any one of these categories. So not any one thing, not even lactate, not even hemodynamics at this time define it. It's more, we wanted to have general classification. You walk in the door and you say, oh, this is a D. This is an E. But I hope that in 10 years from now or 5 years from now, we actually can look at it and say, listen, a heart rate of 120 predicts it. Heart rate's difficult though, because some of these patients have AFib. The post-arrest patients are, have just gotten epinephrine. So heart rate is not so simple.
All right. Well, thank you, panel, and thank you, speakers. It's been a wonderful session, and enjoy the rest of the day. Thank you all.
So obviously, the right heart catheterization, it's a must to diagnose this. Is there any other, is the echo finding enough, Bill, to kind of diagnose the RV failure, or what kind of comments on that?
Yeah, I think the index of suspicion, I think, is really very important, because the anatomic substrate is ischemia or infarction of the right ventricular branches. However that happens. We had a patient 6 years ago that needed a TAVR valve and had a small, dinky little right coronary, huge hyperdominant circ, and there's only a couple of acute marginal branches that went off of that. We put the valve in, and the right coronary occluded, and the patient developed profound refractory right heart failure. And we put the patient on ECMO. There weren't any other support devices for a week, and the patient finally died. And it's just these tiny little branches. So that's kind of the index of suspicion of acute infarction. The other thing is that I think you can be very helpful for the heart surgeons if you have a VAD program. RV failure after a VAD is put in is actually quite a bit of a problem. And those patients respond very well to RV support. You really want to be very optimistic and very aggressive with those patients, because the RV is very resilient. And if you can kind of get them through the crisis at the end of the month, most often the RV has returned to normal function.
So, Bill, we've concentrated on acute coronary syndromes and STEMI in particular, but what about RV support and your thoughts and experience for pulmonary emboli or for patients with ARDS or, non-cardiovascular problems?
Well, there are some protocols that are going on right now for acute right heart failure with pulmonary emboli, and we've done it. I know others have done it, where they put in devices to cause lysis and flow, and I think there's actually some rationale for doing that, because if you put the device in and then have flow established through the pulmonary vasculature, you're actually going to accelerate lysis further. There's no actual formal trial going on, but anecdotally, I think that is a very successful therapy. The other place where we're sort of now toying with this is with severe tricuspid regurgitation and putting in a right heart support to sort of get the blood flow flowing and to try to get the patients out of profound RV failure. We have used it in the circumstance of RV failure with severe pulmonary hypertension, and interestingly, it does seem to work. It does seem to augment forward flow and decrease right heart failure, so that you can get some of those patients out of shock as well. So I would suggest have some cautious optimism from using it in that setting.
So I had a couple of comments. So you mentioned VAD, Dr. O'Neill. So the PAPI cutoff is 1.8, right, for right heart failure when you have a VAD?
Yeah, the one that Naveen Kapoor has talked with us about is 0.9. So that's kind of what the data that we've looked at and the data that he's collated.
There is a difference between the acute settings and the chronic setting. The chronic 1.8 or less, the acute setting 0.9 seems that the ventricle, and that's basically the data from Naveen Kapoor. It's the right heart failure is basically, it's much more vexing and much more complex, and if you mismanage them, their mortality is extremely higher. And we've had patients who basically the right ventricular support saved their life. I have a 57-year-old patient. We clipped the same thing. We did a reverse cart, and they lost one of the RV marginal branch. 6 days in the ICU, but his ventricle recovered completely and actually walked out of the hospital.
Can you comment on large RVs where it's normally so hard to put up the RP impeller? Do you have any tips or tricks that you use?
What do you think, Bill?
I think actually the tandem device actually works much better because it goes in from the IJ over a stiff wire, and that's one circumstance. Now, The problem with the large RV also was there with the original RP device. When we did the trials, it was a bear to get those through, but they've actually changed the contour of the tip of the catheter, and it's become much easier to use. But I think you need to have some familiarity with both. And especially if you think that this patient is going to need chronic support for more than a couple of days. And I think putting it in from the IJ and letting them kind of get up and ambulate is a really good deal.
Yeah.
You know, Tim, the natural history of RV infarction has kind of completely changed. When you and I were fellows, we used to have these patients that would be in the ICU for like 3 weeks, and you would pour fluids into them, and they would develop anasarca. Remember that? I mean, and then like all of a sudden they turn around.
ARDS, they get
This
ARDS.
massive diuresis, and they would actually survive. But those patients, I mean, that's gone now, thank God. I mean, that's one disease that you guys don't have to deal with that kind of has been eliminated by effective reperfusion therapy.
But it's instructive because those patients, if you got them through the acute thing, end up being normal. I mean, I still follow 30 years later several people who are just like that who are normal.
Yeah.
So the ability to recover for the RV is right. So that's why we have to get them through it.
Yeah.
So let me add just one quick, actually practical comment on, most of the STEMIs and ACS, they do not actually happen, the patient do not present in large centers that they have access to all different supports. So I think the economics of this, having different tools to support RV in every single hospital that does PCI, is almost impossible.
Yeah, I agree.
So I think it's very important to have a strong network, and that's how actually we are doing it in Cleveland at University Hospital System. We have about like 12 hospitals, they all do PCI,
Right.
but the RV support is at the main hospital. As soon as we think, the patient needs more than what we can offer, which is usually Impella, we make the phone call and make things happen.
Well, the other thing, no, I totally agree. I think we have to educate our outside doctors too in terms of trying to make the right diagnosis. The patient comes in with acute MI and is hypotensive. If they're not thinking about RV infarction and they're not putting a swan in, then they'll just start jacking up the vasopressors, and the patients are getting worse and worse and worse. And they call you 10 hours later, and they're like in frank refractory shock, and here, fix it. So I think, you don't have to have that device in your cath lab, but at least you can make the diagnosis and then have referral patterns for the hub hospitals to get that.
And if you put an Impella in them, you'll have a lot of section events, and actually if you support the LV, you're going to actually fail the RV worse.